Dr. Bernardo is supposed to be the third speaker. Huh? We have Dr. Stefan with us and Dr. Abbott.
Yes. Do you want to see my slides?
Would you like to try them quickly, please?
Sure.
I'm Dr. Raed from Jordan. Hi, Dr. Abbott.
Hi, nice to meet you. I don't know if you see me. I cannot see myself. Yes, I see myself.
Liz? There, okay.
Okay, I think mine work fine, yeah? You see them?
No, not from my screen.
I can see it.
I can see it.
I see it.
Okay, I'll stop sharing.
So while we are live now, if you want to start.
Yes, I think we are at the clock, and while I think.
Yeah.
Can we start, please?
Yes. So all of us live, guys?
Yeah, we are live.
All the people in the room with us? Okay. So first of all, I would like to thank you all for being with us tonight in this very interesting webinar about the drug-coated balloon and the advances in drug-coated balloon. This great webinar in collaboration with the SCAI, Society of Cardiovascular Angiography and Intervention, and in association also with the EAPCI, and we are at the National Heart Center, Saudi Arabia. In addition to our society, the SACIS, Saudi Arabian Cardiac Intervention Society. We have a well-respected, well-rounded speaker from USA and from Austria and from Saudi Arabia and from Jordan. This is a series of virtual webinar we're going to do over this year. Every time we're going to choose a hot topic. The drug-coated balloon is something now attracting the interventional cardiologists and we would like to know about the technology, about indication, optimization, see cases, and all this will be tonight. I would like to thank Elizabeth and Dr. Abbott and Dr. Bernardo and Dr. Stefan and Dr. Raed, my colleague, Dr. Salem, Dr. Abdullah Saidi, Dr. Khalid Aljohani, for all of them being with us tonight. Without further ado, I will hand the webinar to Dr. Raed Alawaisheh, my friend from Jordan.
Thank you very much, Wail. Thank you for the invitation. Thank you for all participants all over the world for this really interesting topic, as you mentioned, Wail. I think it is the hottest topic these days, and to find out where DCB or DEB has reached to. So with no further delay, I think we will start with Dr. Stefan Harb from Austria. I think it is still the day, It is not tonight there in Austria, as you told me, Dr. Stefan. So you are still fresh. So go ahead, the podium is for you.
Thank you so much for having me in this exciting webinar. I'm Stefan Harb from Austria. My task is actually, can you see my slides?
Yes.
I can see Dawn Abbott. Hi. Okay, good to see you. In some time that we have met. And hi, Wail Alkashkari. We are working together continuously. So my task is to talk about technology behind the DCB. It's quite interesting question because I am usually working practically with that thing. And now I looked a little bit through the literature, what's there. So I'm fascinated by Andreas Grünzig. He started the treatment 1977 just with a regular balloon. There were downsides to that elegant treatment. There was elastic recoil dissection, acute closure, restenosis, but interventional cardiologists and scientists always find solutions. So they invented a stent. At least the acute closure was taken care of now. But there was coming up intimal hyperplasia. So we had to develop anti-proliferative drugs. And we had to put them, I have to put this away because I cannot see my slides here. We had to put them on the stand and created by that a drug-eluting stent. Oops, there's now some, but with that came stent thrombosis, which was really not nice. So we had to use better medication to prevent stent thrombosis. That led to bleeding. So people were thinking, how can we get rid of the stent and still have the joy of the advantages of antiproliferative drugs and put the drugs onto the balloon? But that demanded better lesion preparation. And it's only in the last years that we have achieved lesion preparation in a way that we are not afraid of dissections anymore. We can shred dissection, and now we can do a much better job treating the patient. But my job is not is just the technology behind it, and that started with scientific work in pigs by Bruno Scheller very early, 2001, 2003, and they found that if they combined paclitaxel with just the contrast with iobromide, then they could actually prevent in-stent restenosis in pigs. So they just injected that, kept it there for a while, and looked at it later and saw there was really an effect of the paclitaxel preventing the hyperplasia. And they found, when they looked at the tissue, they did find that the paclitaxel really stayed in the tissue very long. So the half-life was about 1.7 months, which was explained by the lipophilicity of this drug. Here you see just a short outline of the history. You see that it was going parallel. Some were trying to put the antiproliferative drugs onto the stent. Others were trying already at that time to use just a balloon and coat it with a special drug. So a very early work in patients was this small study by Bruno Scheller and his team, and they found that they could do a better job with a drug-coated balloon if it was paclitaxel. So what is actually the difference between drug-eluting stent and drug-eluting balloon? You know that at that time, this is from 2009, there was polymers used to bind the drug to the stent, but the balloon just put the drug, just imprinted the tissue with a paclitaxel that luckily was lipophilic. Very low dose was needed with the stent because it was kept and hidden behind the stent for a long time, whereas the contact with the balloon was only short, so higher dose had to be used in the beginning. Slow and controlled function of the drug was achieved by the stent because it kept the drug right there. Fast release was needed for the DCP because of the short contact time. The strut-based vascular penetration was different from the balloon surface homogeneous distribution. I show a picture to that just in a few minutes. Mechanical support it was staying in the vessel and caging the vessel, whereas the DCP left nothing there except for the drug and the reaction to the drug. So the drug-eluting stent showed less spillage of the drug to the distality, and we still do see embolization of the drug from the drug-eluting balloon. So I want to go to the next picture because this is something that affects actually my practice. This is from a pig study. You see the pattern of the drug in the wall of the vessel, just reflecting what is the contact area of the stent. And down there, you see the homogeneous application of the drug by the balloon, provided the whole balloon is coated with the drug, which was not always the case in the old balloons. This has some practical aspect for me. We have to make sure that the DCP really touches the vessel wall in a nice way. This, for instance, in bifurcations, we really do have to use the balloon first and really apply it to the wall and must not have the stent in the way. And we should apply the drug first and, if needed, kiss later. In this picture, you can see the difference between drug adsorption and drug absorption. You see with a short contact helped by excipients, that activate the drug on the drug-eluting balloon. It can quickly pass the endothelial space and go into the deeper vessel walls, where it has to work on the smooth muscle cells. Sorry. And the drug is then absorbed in the depth of the vessel, whereas the endothelium can heal easily and quickly. Many different agents have been used to activate Baxdrostat cell biolimers and sirolimus, and also different ways of changing the stent, changing the balloon surface have been used. You know that the Baxdrostat is the more toxic drug. We have to be very careful with the dose. We saw this in the Taxus stent program. It's a metotic poison, whereas the sirolimus is less dangerous, let's say. And this you also see in this diagram. You see that there is a small therapeutic window for the Baxdrostat and a much wider window for the sirolimus. On the other hand, it's not easy to make the sirolimus stay long enough in the vessel wall by the drug-eluting balloon. Why would we really want to know about this technology in detail? We can just use the balloon just like we drive a car without knowing how the engine works. Or we could just read the IFU and be comfortable with the one drug-eluting balloon that we use. But I think it's necessary to think about the function, about the way it works, to be ready for potential complications and to optimize the use. So we have to consider that it's in the bloodstream, the drug is really activated soon. We have to make sure that the balloon can pass easily through our plug, and we have to do great lesion preparation, and we have to be patient and give it sufficient contact time. We have very many Baxdrostat cell drug-eluting balloons on the market. I just show one example here. This is the Wail. I'll show this short movie. It's maybe a little bit boring, but it makes us a little bit feel what's going on in there just to see what's happening. You know, I have to wait. You see that it's bulkier. The balloon is bulkier. It's not as slim as the usual balloons. So we really have to prepare the vessel well so that we can get in. And we see the excipient here. We see the Baxdrostat cell, and we also see the urea that is helping it getting activated and going to the vessel. And then it has to enter the vessel wall. The Baxdrostat cell can do that because it's lipophilic. Here you see how the balloon is folded. They made sure that all the folds are filled with the drug. That was not the case earlier with the old balloons, like the Dior balloon was just sprayed on, and it was not nice covering. But still, this is a device like any other interventional device that has to be very slim, has to be able to go through all the obstacles, has to, as you see here, quickly make sure that the drug quickly goes into the vessel wall. Baxdrostat cell can do that. That's quite easy. It's like putting gasoline. It would be like a patch that would not go away. And here you see it's folded again, and the healing process is taking place. There is other Baxdrostat cell balloons, for instance, the Protégé balloon. That's a little bit different. I show you this balloon because it has something like a sponge effect in its polyvinyl pyrrolidone. And so they do advertise in their brochure that maybe you can apply the drug several times with the same balloon, which actually is not the case because it's a lot less and unpredictable in the second and third inflation. And they do not talk about it in those IFUs. And you see how small the printing is in the IFUs. That shows me that nobody reads it. I don't think that anybody really reads the IFUs. But sometimes there are quite nice things in there. Also simple things, like loosen the valve of the epsilon connector. Some people don't do that. They just push the balloon through, and maybe they are not so successful if there is no drug on it anymore. Even though it's not so important, they advertise here that they have a non-compliant version. It's just that different companies are now trying to use different niches to have some application. Non-compliant balloons are en vogue today, but for the drug-eluting balloon, I think it's not important. It's maybe better to have the semi-compliant because you have to know exactly the size if you use a non-compliant, and you are able to go a little bit bigger with very low pressure because you don't need to change the plug, you just apply the drug. So there is also sirolimus-coated balloons, you know them. Some have the sirolimus in crystalline form. Some have it in very delicate micro reservoirs, millions of them, can you imagine? And this achieves a similar effect as with a drug-eluting stent. The drug will stay in the wall and be diluted from those micro reservoirs for up to 90 days, which is great for healing. One more IFU I show you. It's interesting how the IFUs are nowadays created. It shows the data, it shows the dose, it shows what's happening in the blood. If you apply the drug-eluting balloon for a very short time, you have a high concentration in the blood that goes down quickly. It shows also what happens in the tissue. It goes down much slower, but it's this early peak that is important to know. And you see the data of the balloon. You see the crossing profile is a little bit more than with other balloons. You also see how they prepared the balloon. You have to expect that there is drug in the folds, and it can be fully coated when you open the folds and apply it. And then it's also interesting here, if you see what happens up in a few days after. I was amazed that it shows in the IFUs that what is happening on the first day, on the third day, and on the seventh day, that you see that slowly the drug is going from the from the inside of the vessel, from the intima into the media. And then they show how you implant it. So small that you cannot read it. So let's make it a little bit bigger. Naturally, we have to do lesion preparation. What may be interesting, the inflation time is almost the same for all the balloons. It's 30 to 60 seconds. Sometimes people also ask what happens if you do inflate again. You cannot expect more drug to be in the vessel wall then. It's a good information, I think, to know that. Each lesion should be addressed with a separate balloon because there will be no drug left or an unpredictable amount of drug left if you use it a second time. In longer lesions, you have to overlap. In studies, this was not done in the beginning because of the fear of toxicity, but now we know because of the shoulders of the balloon, and there's no danger involved in that if you do overlap more, and especially in ISR, in in-stent restenosis, you have to really make sure the balloon is protruding from the old stent. The take-home messages for the interventionist from my side. I think these are really complex systems. There's not necessarily a class effect, so one balloon will not be like the other. Do not underestimate excipients and other factors. It's not only the drug, certainly also the dose. I think we have to handle them with care. I think we have to make sure that we can easily apply them after perfect lesion preparation. This takes quite some time. It is costly. And we have to know that we have to be patient again then, and really 30 seconds can be very long if you are in a hurry, and we know more than 60 seconds are hardly tolerated by the patient depending on where you apply it. And make sure that you don't have geographical miss, because with the stent you can more easily see where the stent is ending. With a drug-eluting balloon, you really have to keep in mind, if you use several balloons, where the others were. Thank you for your attention.
Thank you very much, Dr. Stefan. This is really an excellent brief, and starting from the history of the DCB or DEB. I think if you have hot questions, can receive them. But meantime, I would like really if Dr. Stefan explain for us the importance of putting polymer or a big amount of the drug on the balloon, so we will not lose the drug while we are delivering it from the sheath to the lesion. So what is the best solution, and what is the drawbacks if we have polymer, what is the positivity, or what's the good thing about folding the balloons? Can you explain this point? from
Well,
technical
in
point?
the polymer we used to have on the drug-eluting stents. Even there, we don't have the polymers anymore. We have polymer-free drug-eluting stents. With the drug-eluting balloon, it's quite many different substances that serve as carriers and as activators. These substances can be like shellac, like a varnish. They can protect the drug on the balloon as long as it's not made wet. Like if you wetten it, activation starts. So then you try to get into the vessel. For some times this will be stable, but like if you have to come back again and because you haven't done enough lesion preparation, you may have spoiled the balloon in a way that it's not usable anymore. I mean, you can use it, but the effect may not be the same. It's about 65% of the drug that is protected inside the folds. So it's a lot less than if you have also the drug that's outside. And you also know that now there is also stents that are sprayed on there, but the balloon is also covered with additional drug. So with sirolimus, it's not so toxic. So they make sure they do not see the pattern that you saw in the green pictures that I showed from the pig. Is this about what you were asking, or is there a special question?
Exactly, because one of the important things is to have the drug delivered to the lesion without loss. So all of these trials were done technically to deliver the drug in the good concentration to the lesion. I like the
Dr. Raed,
yeah.
what do you think if we proceed with the lectures, then we take the discussion at the end, so we keep, yeah. What do you think, guys?
Yeah, I think it's great. Yeah.
Good suggestion.
Yeah.
Okay, so we move to next speaker, and kindly, Dr. Abbott, would you like to talk to us about the indications for DCB? We can see your slides, but we can't hear your voice.
Okay, can you hear?
Yes, that's good.
Okay, perfect. Well, thank you for the invitation to this webinar. I enjoyed that initial talk, and it will certainly be incorporated throughout the discussion, I'm sure.
That's good.
Here's some disclosures. So where are we at today with DCB for coronary lesions? As we just heard, there are many components of the DCB, including the balloon catheter, the lipophilic drug, or ways to make non-lipophilic drugs enter the vessel wall, and potential coatings, activators, and enhancers. The first CE mark was 2007, and there are over 14 companies currently manufacturing these. And we've already heard, but you have to understand there's not a single class effect. So when looking at individual studies of outcomes in specific lesion subsets, you have to look at which DCB was examined. And we already know several theoretic advantages, which were just discussed. Outside of the US, in many countries, there have been increasing use, particularly in the lesion subsets of in-stent restenosis and small vessels. In countries, large countries like in Asia, the use is upward of 1 in 5 PCIs. We just had the first FDA-approved paclitaxel DCB in the US in 2024. So that was really a landmark for us in the US. And they were, paclitaxel balloon was specifically approved for in-stent restenosis. And we already heard it's certainly may shorten the duration of ADAPT, which can be a benefit in high bleeding risk patients, which I won't be discussing today. So just to start off, with the AGENT trial, which is how we got DCBs in the United States. This was comparing drug-coated balloons to plain old balloon angioplasty in ISR. Now, in contemporary management, particularly outside the US, plain old balloon angioplasty has not been used in over a decade, but it was how this trial was designed in order to get FDA approval, where the paclitaxel DCB was compared to an uncoated balloon in a 2-to-1 fashion across 40 centers. And we saw a significant reduction in target lesion failure, which of course is expected. And you can see that occurred early, and the ischemia-driven target vessel and lesion revascularization, as well as myocardial infarction, rates being lower in DCB, these both continued to persist and diverge out to 12 months, showing really the superiority of DCB to POBA for ISR. So I think that's really wasn't a question in anyone's mind, but now that has allowed us to have them on our shelves for management. And more recently, it's become more debatable if you have both DCB and a DES available, what is the optimal device choice for a patient with in-stent restenosis? Okay, previously, both DES and DCB received a Class 1 indication in the ESC guidelines, but more recently, in 2024, DES was recommended over DCB for DES restenosis based on a meta-analysis with outcomes out to 3 years, which would be interesting to discuss. In this meta-analysis, they did break down whether the treatment of ISR was for bare metal or drug-eluting stents. I can say that in most cath labs in the United States in the past 5 years, there are no bare metal stents on the shelf. So bare metal stent restenosis really may become completely irrelevant. And I'm not sure that the minutia of looking at these outcomes based on initial stent type is really warranted. But in this detailed meta-analysis, the DCBs were found to be more effective than DES for bare metal stent restenosis, but not for drug-eluting stent restenosis. And when we look at the overall specific outcomes examined, the main reason that the ESC changed their recommendations was really based on efficacy, with higher rates of ischemia-driven target lesion revascularization in drug-coated balloons out to 3 years. However, there was no signal of any other differences and definitely no safety concerns. And in fact, one can consider either of them for an individual patient. In particular, if a patient already has 2 layers of stent, has a stent that's difficult to expand, has a stent in a small vessel, there still may be reasons to choose a drug-coated balloon over a drug-eluting stent for a patient with restenosis. One caveat in the United States is that a drug-coated balloon is $5,000, over $5,000, and a drug-eluting stent in general is about $400. So economically, when we have patients with drug-eluting stent restenosis that are optimal candidates for a second layer of stent, we are currently in general using a second layer of stent, but reserving the drug-coated balloon for those circumstances which I spoke of, where we feel there would be a potential harm or disadvantage to placement of a second layer of stent. Hopefully in the future, when economic considerations are not as strong, they can be used more widely. What about de novo lesions? Well, we certainly don't have time to talk about every lesion subset that has been studied with drug-coated balloons. You can see by this meta-analysis that overall, there is data favoring the DCB on a relative risk being lower, but that it's all over the place depending on which lesion type you're talking about. So it's been studied in small vessels, large vessels, bifurcations, CTOs, and STEMI, even STEMI. And many of these lesion subsets have been studied in very small sample size of patients. So I'm going to focus the rest of the talk on where we have more consistent randomized data. So let's move to small vessels. We have many experts on this call in the field of small vessel DCB, like Dr. Cortese, who's designed many of these trials. So it'd be interesting to get his insight. But the strength of the data really does rest in the small vessel trials, where we see that DCB versus DES is definitely non-inferior in terms of the efficacy. And there is some data on lower stent thrombosis and MI, which is really impressive in terms of safety, given how safe our current drug-eluting stent devices are. And I would also say that many of these trials included imaging follow-up, and positive remodeling was often seen upward of 40% of these patients, which is highly preferred and desired particularly in small vessels where you don't want to cage the artery and prevent the positive remodeling. So I think in my mind, this is the lesion subset outside of ISR that has getting the most use around the world. And here's just to summarize again, where the target vessel thrombosis, myocardial infarction, although these don't meet statistical significance in individual trials, have shown benefits and the trends are favorable, and the efficacy is similar to DES. So in my mind, that's a very good population. As a matter of fact, in the United States, at our hospital, we are currently enrolling in 2 trials of de novo small vessels. One of them, the solutions with the sirolimus balloon, and the second is the Prevail paclitaxel balloon from Medtronic, which Dr. Harb showed us the mechanism of that balloon. So we will hopefully have a drug-coated balloon in the United States soon for small vessel de novo lesions. What about outside of small vessels? There is some concern that in larger vessels, the DES may be more effective. I think the jury is still out, and I think there may be a lot of opportunity for hybrid approaches, which people have already mentioned, where you use scaffold some of the vessel with a drug-eluting stent and maybe use the drug-coated balloon for the longer lesions extending into the more mid to distal vessels, or in the case of hybrid procedures such as bifurcations. But here is some more emerging data that maybe DCBs will make a comeback in large vessels, because again, you can see some favorable outcomes, and I think it really deserves a very large randomized trial before we make a final judgment on the use in large vessels. In the US, I think it will be quite a long time before people are testing it in things like left main, but it is being examined outside the US, even for left main disease. So there are some really brave operators out there with a really strong belief in drug-coated balloons. Well, what about bifurcations? I just chose one, which is the BIF DCB, because it's the most recent and it received a lot of press. But prior to this trial, there were upward of 6 different trials with different designs. The difficulty in the bifurcation literature with drug-coated balloons is that the trials were designed all differently, some with bare metal stents with drug-coated balloons, some with drug-eluting stents and drug-coated balloons, some with drug-coated balloons in main vessels or side branches done before or after stenting. And we already heard this may impact the function or efficacy of the balloon. But in BIF DCB, this was a trial of provisional stenting for true bifurcation lesions, where after the initial procedural management and stenting, if there were residual side branch stenosis of greater than 70%, the patients were randomized to a non-compliant balloon versus a DCB. And you can see the DCB in that circumstance was highly effective and reduced the target vascular revascularization and MACE, particularly in the side branch, with a relative reduction of over 40%. So I think we will be seeing a lot more studies. I know Dr. Cortese is designing a 3 comparison study with drug-coated balloons looking at use in both main vessel and side branch. Maybe he will tell us a little more about that trial. So where is the field going? Like I said, in the United States, we have several, there's at least 3 different devices in trials for small vessels. The agent balloon with Boston Scientific is also going to be studied in complex lesions, such as bifurcations. And there are a lot of indications outside the ones I've discussed going on outside the US, including things like left main and very complex diseases, acute MIs, CTOs, you name it. I think it's being studied. Ultimately, there may be patients in which a hybrid approach makes the most sense. And I think there is data supporting bailing out to a stent if you have flow-limiting dissection with drug-coated balloon. Hopefully, we wouldn't have some suboptimal vessel prep, which is under our control, but sometimes after deployment of the drug-coated balloon, there can be dissections that necessitate bailout stenting, which appears to be very safe, so that we should be reassured. I also want to bring up, not the topic of this webinar, but I'm very excited about the re-emergence of vascular scaffolds. I do believe with the magnesium-based scaffolds, and some hybrid devices, such as the bioadapter, that we will see these devices also competing with drug-coated balloons in the future. And like I mentioned, in the US, we have a lot of barriers to adoption. And I think that's one reason they are infrequently used. But I think over time, as the cost comes down and we can train physicians on optimal use, these will become standard of care here as well. So thank you very much for the invitation and looking forward to the discussion on indications.
Thank you very much, Dr. Abbott. For the sake of time, as we agreed, we keep the discussion to the end of the talks. So with no further delay, I would like to have Dr. Bernardo Cortese. Would you like to talk to us about the intravascular imaging optimization for DCB angioplasty, please?
Yes, thank you. I hope that you are seeing my slides and also listen to my voice.
Yes, you are
I'm
great.
really happy. Thank you. I'm really happy to be here, and thank you for the invitation. You know, my passion is about complex PCI and DCB, and today the topic will be one of the most interesting topics, and this is one of the questions that I receive more often, which is it there, and which is the role of intravascular imaging and physiology for DCB angioplasty? As Dr. Abbott has just shown, the indications for DCBs are not clear, but they are growing. So in the US, we can use DCB for ISR. Outside of the US, we can use them for small vessel disease, but there is a growing number of patients being treated for larger vessels and hybriding risk or bifurcation lesions. So there are many topics that, many areas where DCBs are being investigated or already have robust evidence. And one of the most robust evidence is small vessel disease. I want to present you this data from our group. This is a patient-level meta-analysis of comparison between DES and drug-coated balloons in small vessels, up to 3 millimeters, okay? But the difference here is that the primary endpoint is clinical, 1, and 2, we have long-term follow-up. So we have the patient-level data of this 4 randomized clinical trial with a minimum of 3-year follow-up. And for the first time, we are showing a reduction in MACE, primary endpoint of this meta-analysis, between drug-coated balloons and DES, meaning that DCB, all of them in this study in this meta-analysis where paclitaxel are reducing the rate of MACE after 3 years. And that's quite important and is leading us to say that for us, the first indication of treatment for small vessels, if you achieve a good lesion preparation, should be drug-coated balloon. Again, unfortunately, outside of the US because of the lack of indication here and reimbursement, and that's also another topic. Another important paper I would like you to go and download is this DCB ARC. So this is a huge effort that many of the most renowned experts on DCB in the world made. We came out with this publication a few weeks ago, I think a couple of weeks ago in the European Heart Journal. Patrick Serraios was the coordinator of this, and this is like do you remember the ARC for stents back in 2007? So this is the same thing for DCB. So in this manuscript, we are delving into the details on when to use DCB. And there are also some important information about the usage of DCB with intravascular imaging and physiology, but you could be surprised by the lack of clear data about this. And this is what I'm trying to show you. And I would like to start with this case. So this is a CTO that I did during one of my courses in an outside hospital for this LAD. So we reopened the vessel. So I'm not going to go into the details of the CTO itself, but intravascular imaging here was so important to understand what we have achieved. And in a little while, you will see some nice dissections that we have obtained at this, you get here, at this part of the vessel where we had a proximal cap, okay, where the CTO was. There was a calcification and nice dissections created by the cutting balloon that we used. So now at this stage, what can we do? Okay, you can see here that we have a quite nasty dissection. In the vast majority of the cases, you would end up stenting. But here we wanted to gather more information to see if really this vessel with this difference in terms of vessel size would have required a stent. So we did the physiology. We used in this case a microcatheter. Microcatheter showed distally a significant positive FFR, which was related to the fact that the microcatheter was stuck distally and the vessel was hypoperfused. So this is not something that we are going to treat by any means of any device. What is important is to see this jump. Is this jump associated with a reduction, with a significant loss in FFR? And it is not, because FFR here was 0.92 and more proximate it was 0.96. So we have achieved a good lesion preparation in terms of perfusion, and that's enough for us to go on with the 2 drug-coated balloons. Here in this case we use sirolimus, having obtained a good result. Then you check it again after a few minutes in an orthogonal view. You don't have recoil, you don't have a impairment in the flow, and then you're done. So this is an example of how you can use physiology for lesion preparation. And this is another case that I got from Antonio Colombo. Antonio is presenting this case quite often. You can see here on the left an initial physiological assessment after initial lesion preparation. I say initial because lesion preparation should last the time needed to prepare the vessel for the final treatment. And I'm saying that for DCB, but I'm also saying that for drug-eluting stent. So lesion preparation doesn't mean that you have done your duty just dilating a balloon or use the rota, a small balloon, and then you are done. No, you have to assess it, and you can assess it with physiology. And with physiology, on the left, this is not a good lesion preparation. On the right, after the usage of scoring balloons, that's a good lesion preparation with a PDPA and FFR assessment, which was completely negative. At that stage, you can go on with a final treatment, which could be stent, if you want, or drug-coated balloon, like was the case. So some data for the help of physiology. So this study was published a few years ago, and it's quite important because it's a mechanistic study, it's a retrospective study, whatever, but it's very intelligent. And this study is showing how the QFR gradient between the distal part and the proximal part of the lesion. I repeat, the QFR gradient, the difference in QFR between the distal part of the lesion and the proximal part was the major determinant in saying this patient will have TLR or not. And it was more determinant and more important than other commonly used parameters. And in this study, they used all of the QCA normal parameters like person diameter stenosis, like binary stenosis. All of these were less sensible to detect the possibility of having TLR during angiographic follow-up. So another potential usage of physiology is to see how is the final QFR gradient. And then we have some more data coming up very recently. We presented the preliminary data at EuroPCR of Piccoletto 6, EuroPCR last year, and the final data at TCT. So here we wanted to compare the performance of paclitaxel and sirolimus-coated balloons, not by means of angiographic performance, but by means of physiological performance. For doing that, we invented, I would say, a new primary endpoint, which is a late functional loss. Late functional loss is the difference between the μFR at the end of the PCI with DCB and during angiographic follow-up. For Piccoletto 6, we enrolled almost 300 patients for small vessel disease, all undergoing angiographic follow-up. And we compare the performance of paclitaxel and sirolimus-coated balloon, as I was saying earlier. So this is a real small vessel disease study. Lesion length is quite long. It's on average 24%. We have 40% of the patients with a long diffuse disease, which means more than 30 millimeters. And as expected, late lumen loss was good for both. Paclitaxel in this case did beat sirolimus. We know that the lumen enlargement with paclitaxel is higher than with sirolimus, and it occurred in 60% of the cases, though I have to say that also sirolimus was able to determine late lumen enlargement. But the primary endpoint of the study is the difference in mu-FR, how we call late functional loss. And late functional loss was not different between pancreatic-coated balloons and sirolimus-coated balloons. Another important information that we got from Piccoletto 6 study is which is the final cutoff in terms of mu-FR, or which is equivalent to FFR, to predict PLR during clinical follow-up. And in this case, clinical follow-up was up to 1 year. So we know this cutoff for stents by the study of Collet was identified as being 0.91. For DCB, it's lower. So DCB is pardoning more, also thanks, I think, to the possibility of having lumen enlargement. So this cutoff for DCB as a final mu-FR is 0.86, which means that if you have 0.86 or above, you have low events. If you have below 0.86, you have to do something else, or you have to stent your lesion, because DCB is not enough to warrant lower events during follow-up. So the second part of this presentation is about intravascular imaging guidance. So we have this case. I did this case during one of my proctorships, and in this case, I was in Indonesia. So this patient came for a non-STEMI with this left main and proximal AD disease, which we assessed with OCT, and we were able to identify this quite thick calcified nodule in the proximal part of the LAD. So we decided to go with ROTA. We repaired the lesion with the semi-compliance and then later with the scoring balloons. And we spent some time, despite it was a live case during a Congress, we spent some time in preparing the lesion. This was the best we could achieve. Is this a good lesion preparation? We don't think so, of course. So we need to stent this lesion. And this is what we did. We put a stent from the ostium of the left main to the proximal AD, and then we reassessed. We still have dissection there, but then we wanted to understand better the dissection. And this is the utility of OCT, or also IVUS in this case, but specifically we use OCT, it's the same, which is how is the area? First of all, we have to assess how is the stent. So the stent was good, circ was good, so nothing we had to touch. Proximal AD, where we had the calcified nodule, the stent was well expanded distally. So distally, we were able to understand that the area was good, that the dissection was not severe, and merging this information with angiographic parameters, which were showing a good T-metry flow and no recoil, that was enough for us to go for DCB. So we used a long DCB trio by 35, just distal to the stent, and this is the final result that we achieved. You wait a few minutes, you have a good T-metry flow, and then you stop. Patient was asymptomatic at that stage and was discharged without complications. And I'm also happy to present you the 3 months follow-up that the guys there sent me, showing the great result, maintained result without the need of putting a second stent, doing a chemin de fer, which is something that we have to avoid in 2025. You have to put stents where you need, but like left main, of course, but where you can treat the lesion with a drug-coated balloon, that's enough. And look at here, this bridging in the mid part of the LAD. I'm so happy that we did not end up putting a stent there. The role of intravascular imaging for DCB is quite clear to me, though we don't have important clinical data coming from clinical trials. I'm going to that in a couple of minutes. The most important part is understanding the lesion. Okay, so that's the most important part. You don't have to use drug-coated balloon angioplasty. You have to use the imaging to understand if you need to put a stent after DCB. So that's something that we don't need to do. We don't have enough experience in doing that, and we don't have enough data. And the consequence of using intravascular imaging, if to decide to use stent in the end, is that you would end up in doing a lot of bailout stent. As I said, intravascular imaging is instead very important in the first part of the angioplasty, because we have seen, and this is a very brilliant study from our Japanese colleagues, Yamamoto and colleagues, which is showing how some lesions are associated with more lumen enlargement, which is something that is so fascinating we want to achieve with DCB. For example, the fibrous plaque and the mixed plaques are having more lumen enlargement as compared to calcified plaque or fully lipid plaques. And again, calcified nodules, if you don't treat calcified nodules correctly, DCB is not going to work. So it's not magic. It's like stents. It's not magic. It's not going to work if you don't do correct atherectomy. On the other hand, if you have an eroded plaque, that's associated with a good clinical outcome. So importance of intravascular imaging. And I want to show you also this last study about, well, not the last, a similar study about intravascular imaging, which is showing how if you have a medial dissection and if you don't have too much calcification, you're going to have amazing results in terms of clinical performance at years of distance from the angioplasty. So dissections, as Stefan was saying earlier, are good. We showed that back in 2015 in a paper in JACC Interventional with angiographic follow-up. If you have a good flow, if you leave a dissection, that's even better for drug-coated balloons, which is quite different from drug-eluting stents. Data about clinical performance of intravascular imaging and clinical adjuvants for DCB angioplasty is deriving from this recently published Ultimate 3 trial, which is showing without long-term clinical data, but with an angiographic follow-up that if you base imaging for preparing the lesions for DCB, you're going to have an improved angiographic performance. And I'm going to finish with this last case, which is showing how imaging is important, not only for the fact that we use it for CTO management. Here we had a CTO of the medial AD for ISR. We were able to puncture the cap thanks to intravascular imaging, and it was ISR. And then we decided to go and to try to reopen the vessel with a sparing a further metal. And then after lesion preparation, we obtained this result, which is pretty good. It's adequate. Of course, the TIMI flow is not brilliant because this is a CTO, but that's a good lesion preparation. So at this stage, you can decide to deliver the drug. And this is what we did. We used paclitaxel distally, and we used sirolimus where we had the ISR in this specific case. And this is the final result. Again, there is some dissection distally, which is not, also with the vessel, which is not well expanded due to the CTO, but that's more than enough. So here you don't have to put other metal or stents. Also for this case, we have an angiographic follow-up after 6 months and look at how the vessel is increased in terms of size, and look at the IVUS, which is showing here, just distal to the stent, how the vessel is completely healed without any sign of dissection. And I just added this slide because Dr. Abdul asked me to. The next frontier is to compare drug-coated balloons. In this case, for Transform 2 is sirolimus-coated balloon to drug-eluting stent for native vessel disease. So Transform 2 is a randomized clinical trial with vessel between 2.0 and 3.5 millimeters. Also long lesions up to 50 millimeters are accepted. We prepare the lesion. We randomize the patients to Zions drug-eluting stent and Magic Touch sirolimus-coated balloon. But here we want to see the non-inferiority at 1 year in terms of clinical performance, TLF, and the potential subsequent superiority for NACE and for longer-term follow-up. And I'm happy to share that we have achieved 93% of the final enrollment for this study. So my conclusion, is there any role for physiology and imaging in DCB PCI? As a state-of-the-art DCB PCI, I have to say that angiographic parameters are enough for the majority of the cases. Small vessel disease bifurcation. So you don't have to rely on physiology and imaging for the vast majority of the case. Something is different if you want to understand the lesion better. For that, you have to use imaging. But for assessing the final result, angiographic parameters are more than enough. If you have some doubts in some specific case, I would say between 10 to 20% of the cases, you can use physiology to tell you if you should stent the lesion or not. Whereas for this specific task, intravascular imaging should not be used because you would end up in bailout stenting the majority of your lesions. And then, as I said, we also have a μFR final cutoff, which is able to determine the TLR rate. So if you have 0.86 and above, it's good. If you have below, you should consider to go on preparing the lesion or stenting the lesion. But intravascular imaging, I want to underline this as a fundamental role for lesion preparation. Thank you for your attention.
That was a fantastic talk, Dr. Bernardo, and really we enjoyed, as usual. Perfect example and make it really very, very clear for us. So if you allow me, Dr. Raed, I will introduce the next speaker. Then at the end, there is a lot of question from the participant. You can, share it with us and a lot of interesting question. So the next speaker, my friend and my colleague, Dr. Salem Assiri, consultant interventional cardiologist from King Fahd Armed Force Hospital, Jeddah. And I'm sure he will show us a very interesting cases. And Salem, the floor is yours, my friend.
Well, thank you so much for having me. Let me just share my slide. And I'm happy to. Second. So do you guys see my slides?
Yes.
Yeah,
Okay.
we see it.
Very good. So I have two quick cases that I want to share with you guys. And, the first one, there was a 59-year-old gentleman who has a history of hypertension and hyperlipidemia. In February of 2022, he was admitted with unstable angina and reported that the chest pain was actually been there for the last 2 months prior, but he didn't seek any medical care at that time, and he tried to, wait. The ECG showed an anterior T-wave changes, echo pretty much normal, no regional motion abnormality. And you can see here, this is his cath. You can see the RCA, maybe a sluggish flow distally, but nothing, no obstructive disease. And you can see the retrograde, filling to the LAD. And on the right side, you can see the LAD CTO, but it's kind of short segment, prior to that large diagonal takeoff or diag 2 takeoff. So the decision at that time to take him off of the table, and that's what we did. But then when I came to him and about to discharge him in medical therapy, he insisted on me that, his chest pain has been bothering him for 2-3 months. And because it's a short segment, we decided to give him the benefit of doubt and try to open the CTO. So we do a double injection for the LAD and RCA, and then we open the LAD. We did a CTO LAD intervention, and it was IFAS guided, but I tried to simplify the case. I did wire the diag, but I left him with this pinched diag, and I decided to keep him on that, to leave it at that for medical therapy. So I discharged him on DAPT, statin, beta blocker, and izobide. And then 3 months later, he came again with chest pain, class 3 angina, and you can see the diag is pinched, but the LAD stent looks just fine, and TIMI-3 in the LAD. So we decided then to actually intervene on the diag at this point. So I wired both the LAD and the diag, and I pre-dilated with 2.0 NC balloon, then performed the PCI with 2.25 by 15 Prevail drug-coated balloon for 90 seconds at 8 atmosphere. And this is the final result. You can see a residual of 30%, but I accepted the result. And then 2 years later, or almost 2 years later, last year, he came to a colleague with chest pain, and he performed the RCA was totally fine. And you can see the diagonal is patent after 2 years, with, I would say, residual on the osteal 10-20%. So we accepted, the results, and we decided to continue medical therapy. So the other case is a 68-year-old lady, DM controlled hypertension, dyslipidemia, complex coronary artery disease, PCI to the RCA 2018 and PCI to LAD 2021, complicated by in-stent thrombosis, status post-thrombectomy at the same admission but different session. And then 3 years later, admitted with low-risk non-ST elevation MI. Echo showed a moderately reduced ejection fraction, 35 to 40% with akinetic ABEX, probably secondary to the previous MI because the ejection fraction was pretty much the same, inferior severe hypokinesis, and no significant valvular disease. And you can see the RCA. Again, the previous RCA stent was in the proximal. I can see now a focal, 90% in the distal RCA, and a long disease in the mid PDA. But that's maybe too ovisceral. And the left system showed a widely patent long stent in the mid LAD and a diffuse disease in the circ that it's not amenable to BCI and also known from 40 years prior. So, given that, the PDA is long lesion, small small vessel, I predilated the distal RCA, predilated the PDA, and I end up with long DCB 2.0 by 40 DCB for 90 seconds at 8 atmosphere. And you can see here, I left him with a dissection. Great results in the distal RCA, but you can see, I would say, type B dissection in the PDA, TIMI 3, and I left it, at there because I don't want to complicate. The bailout was a long stenting, and you don't know where to stop. So, these are a couple examples that I use the DEB. I trained in the US 5 years ago. No much experience during my fellowship, but since I practice and been doing it for small, long distal diseases with a strict bailout strategy, just in case if I struggle. Also, I do it for the side branch because I don't want to do a lot of metal. As long as the side branch is a smallish 2.5 or 2.25. Those are my usages for the DCB nowadays. And I have a couple cases that I used imaging to decide whether to put a stent or not after the DCB. Thank you.
Thank you.
Thank you very much. Thank you, Salem. That was a great 2 cases, and we'll continue, to move to the next speaker. I can see a lot of questions waiting for the discussion. So the next speaker, Dr. Abdulaziz Alturki from Diriyah Hospital. Dr. Abdulaziz is a rising star in interventional cardiology, and I'm very sure he will show us a very nice cases. Go ahead, Abdulaziz.
Hello, everybody. Can you hear me?
Yes, we hear you and we see you, my friend.
Great. Thank you so much, Dr. Wail, for the invitation. My case is going to be short and sweet. My patient is a 47-year-old male smoker, hypertensive and diabetic. He was initially admitted to the hospital with the non-ST elevation MI. He developed transient ST elevation during his stay in the hospital, and so we decided to take him urgently to the cath lab. And this is the diagnostic angiogram. You can see that this LCX has an occluded OM. There's really poor flow here, so we decided to wire, and then we prepped the lesion with a 275 by 30 millimeter NC balloon. You can see after wiring that the OM is big. And so after prepping the lesion, we decided to go with a 275 by 30 millimeter Magic Touch drug-eluting balloon. And this is the final result. You can see that there is some residual stenosis in the osteum. So just want to go was normal from the start. So just a brief talk about the use of drug-eluting balloon in STEMI. So there were multiple trials that examined the use of drug-eluting balloon either as a standalone versus drug-eluting stent or as an add-on treatment like mentioned by Dr. Abbott. So I'm just going to mention one important trial, which was the Revelation trial. It compared paclitaxel drug-eluting balloon versus everolimus drug-eluting stents and STEMI patients during primary PCI. The design was randomized. It was a multi-center, non-inferior trial. It had 120 patients only, and it examined drug-eluting balloon paclitaxel coated versus everolimus drug-eluting stent. And the primary endpoint was an FFR measurement at 9 months. The secondary endpoint was MACE, including target vessel revascularization and late luminal loss. So the key results was that drug-eluting balloon was non-inferior to drug-eluting stents for FFR, and it has had similar MACE rates. There was no significant death in both groups. And then there was a follow-up trial, which was a follow-up to the study, 5 years, published in the TCT, which showed that it was still the same, that the result was still the same. Drug-eluting balloons were non-inferior to drug-eluting stents. Now, if you go into the limitation of the trial, you can see that it was a single-center study, and there were only 120 patients, and they used only paclitaxel drug-eluting balloons. And there was a potential for selection bias because the randomization was dependent on the operator. So that's it. I hope that was short and sweet. Thank you so much.
Thank you very much, Abdulaziz. Really, this is a very important case, and I'm sure there will be a lot of discussion about the use of a drug-coated balloon in case of a STEMI. So the next speaker is Dr. Khalid Aljohani, consultant in interventional cardiology, a long-time friend, great operator, great CT operator. Khalid, wow, you are in a scrub, man. So the floor is yours. So we're going to see a hot cases.
Yes, yes, indeed. Assalamu alaikum, everyone. Thanks, Dr. Wail, for your presentation. I actually tried to present, because I have a lot of experience since I was a fellow in Canada with drug-eluting balloon, and I adapted it. Actually, I was one of the early adapters in my center, and I have a lot of different cases. And for today's talk, I want to get conflicting cases, and maybe we'll hear the discussion about it. So Deb, yay or nay in 2 cases. I'm a true, big, huge, whatever adjective you have for DEB, just copy and paste it for me. I use it a lot. It's a must have in my cath lab table. I usually start with this slide for any DEB talk. Most of the people surrounded me, they do have skepticism, doubt about the use of drug-eluting balloon. How come there is a dissection, there is a clot? Should we use it? Maybe this is, I think, the current situation before we start the first case. My first case was a regular case, not so difficult. 50 years old female, diabetic, dyslipidemic, admitted early in the morning with a non-STEMI. I pushed for an echo and it was normal. And that's her angiogram showing mild disease in the LAD and bifurcating stenosis in the LCXOM, not so complex again. LAD has mild disease. So I elected in this case, since she was youngish, which is the trend I do, smallish vessel, to go with drug-eluting balloon only, a strategy for both the bifurcating lesion. The RCA is normal, and we can go directly to the results. So I start with ballooning the main vessel. I saw that the main vessel, which is a key important element that you have to really prepare your lesion well if you want to succeed in drug-eluting balloon. So I ballooned it again with an NC and achieved good results. Then I went with drug-eluting balloon, the side branch, then the main branch with, to me, what looks like a very good acceptable result with no clear aggressive dissections. So with that, I left the patient. I gave her a lot of nitro. She was asymptomatic, but I was happily driving my Porsche home. And then the fellow called me, there is a STEMI, and it was the same patient. She was actually in recovery. And that was her, it's not playing. That was her first injection after maybe half an hour. I was just 10 minutes away from the hospital. So I wired both, and I knew that I didn't do a good job because I turned a non-STEMI into a STEMI. So I ended up stenting it with provisionally into the side branch. with this final results. I know now I pushed people a lot to become skeptical, doubtful, but wait, not so fast. Although the lesion was prepared well, the patient was a good candidate for DEB, but in retrospect, I actually investigated the case because this is maybe one of the few cases that I did have some similar outcome. I realized that this patient wasn't prepped well in terms of dual antiplatelets. She was just giving the dual antiplatelet on the table, which is something I hate when I do PCI, especially when you intervene. I like to marinate the vessels with the drug-eluting balloon, with the dual antiplatelets. For this patient, I believe that the reason for the failure wasn't the drug-eluting balloon itself, rather than the pre-medication that wasn't appropriate because in a rush, and she came at the right time for the right purposes. So I push for people to give drug-eluting balloon or for any PCI to give DAPT in a good time before the lesion, not on the table. For the case number 2, which is actually for the A part, and I'm proud of it actually, and I'm publishing it. It's a 52-year-old gentleman smoker, pre-diabetic dyslipidemic, presented also with non-STEMI, and his cath showed double vessel disease, including a CTO of the LAD. He refused CABG. He works actually in the hospital, and he knows all the surgeon, and despite that, he did not want surgery. So he insisted on having a PCI intervention. A probing of the LAD, because we didn't know if it's a CTO or not. It proved that it's actually a CTO with the wire test of a pilot 150. And then we went into the CERC, which was also the culprit for his non-STEMI, presumably. We went directly and prepared it with balloons and then drug-eluting balloon. Again, my team, the nursing staff were very skeptical. They said, Dr. Khalid, why you're not stenting it? This is non-STEMI. We have a lesion. I said, I'm going to bring this patient 6 weeks after to intervene on his CTO, and you'll see how good is his drug-eluting balloon, where vessels grow, actually. So I left him with these results, fixing the CERC, and giving that it's an LAD and it's a viable anterior wall. I scheduled him. This is the final result for the drug-eluting balloon of the CERC. So I brought him back after 6 weeks to do CTO intervention of the LAD. It wasn't very complicated. It was antegrade wire escalation, very easy LAD crossing successfully with a wire, microcatheter, pre-dilatation, and then massaging the vessel, as I call it. I took my time. I'm not in a rush. CTO intervention requires a lot of patience. I took my time, took different angulation to check for any visible dissections. You can see that there is some spiral dissection in the LAD. The patient pegged me not to put stent. He knows the bad or the evil side of the stent, where restenosis and they come in failure. They said, if you can get away with drug-eluting balloon, can you do it? Well, it's not unreasonable request in 2025. There are many cases of CTO intervention with only drug-eluting balloon, mostly failures, but we see that we can treat these patients with CTO with drug-eluting balloon only. So this is the final results. You can see that there is some dissections at the mid of the lesion. As long as you don't freak out, be ignorant and brave. And I waited for 50 minutes because I don't want to have a thrombosis, acute closure of the LAD. And that was after 50 minutes of waiting. I chatted with the team about stocks and how to sell and when to buy. And that was the final result. I'm actually planning to bring him after 3 months. As you can see clearly that there is a type A dissection in the mid of the LAD. And this is the paper that was mentioned by Dr. Harb about dissection that don't get freak out when you see them. It's not bad. Most of them resolve. And if you can avoid putting a stent, hopefully I switched you now to the enthusiastic adapters to be more able to do more drug-eluting balloon. As we know, this is the take-home message. This is the wheel of evolution. We started with BOBA, then we brought the BMS, and then we're solving the BMS problem with the DS. Now we're solving the DS problem with the DEB, and I think it will be the future, and it will be the standard of care for most of coronary lesion. Thank you so much.
Thank you, Khalid. That was two great real-life example. Really, we like the way you show it to us. And with the final speaker, Dr. Abdullah Saidi is my partner, and he's my co-worker at the hospital, great operator, interventional cardiologist at the King Faisal Cardiac Center. And I'm quite sure you will enjoy his talk as usual. Go ahead, Abdullah.
Thank you, Wail. Thank you for the invitation. So basically, I'm going to speak about using DCP generally in two clinical indications, acute coronary syndrome and ISR. So we know already that drug-coated balloon already has tremendous indications, well established, like in instant restenosis, de novo small vessel lesions, as well as large vessel lesions, also in bifurcation and high-risk bleeding to avoid prolonged dual antiplatelet therapy, and in patients with diabetes. However, what about using drug-coated balloon acute coronary syndrome? So when you look to the technology, basically, as shown by Dr. Harb, that DCB actually, once it's delivered, then followed by the inflation of the balloon, then this mechanism of mechanical, basically, inflation help actually distribute later on the antiproliferative drug that actually used as the main mechanism. Now, when you look at the study done in SACIS patient, this is probably the first study done ever using DCB in acute coronary syndrome. It was done in 100 STEMI patients. It was single-arm study. 59 patients treated DCB angioplasty successfully, and 41 actually after using DCP, they did that basically because of type C and type F dissections. They went up to have basically the drug-eluting stent. So in this study, basically, as you could look, after 1 year, actually, there is only 5 patients out of 10. They have basically MACE in form of cardiac mortality and TLR. And this is basically just to show that using DCP in a STEMI patient is feasible. And at least this is encouraging more study to be done. When you look at the next study done in 120 STEMI patients, it was basically physiology-based study looking at FFR at 9 months for patient around 120 patients. They have randomized basically to two groups. One receive drug-eluting stent and the other group DCB. And as you can see, in 9 months, the FFR study in those patients actually was comparable. And as you can see, also in 1 year and 2 years, actually, in no difference when we talk about lumen loss. Now, looking at different population in non-STEMI patient, we have already shown by Dr. basically Turki that Revelation study, more than 200 patients randomized to either having DCP alone or patients who have drug-eluting stent or beta stent. As you can see, this is relatively old studies. From those who already has DCP, actually 15% required who have basically these stent as bailout strategy. And you could see also in the details of that patient, around 56% they have already bare metal stent. And again, looking at basically the TLF and the MACE, and MACE has bare protocol analysis in those patients. At 1 year, there is actually non-inferiority when you talk about using DCB in non-STEMI patients. Now, looking at subgroup analysis on patient from basket small trial, there is actually, when we look to how many SACIS patients from those patients, around 28% of patients enrolled in a basket small study. As you know, these patients who treated small vessel disease with the DCP, actually, when you look to the differences, the subgroup analysis between chronic coronary syndrome and acute coronary syndrome, there is no actually any interaction, the results when you talk generally about those patients. When you talk about like mortality, MACE, non-cardiac MI, non-cardiac death, and basically other surrogate, including TFR, there is no TTR, no differences between chronic and acute coronary syndrome patients. Now I'm going to go to the first study, 48-year-old, diabetic end-stage renal disease, ischemic with previous BCI to LAD and RCA, came to our hospital with non-STEMI. Echo showed ejection fraction around 45%. The left system showed patent stent, and as you can see in the proximal LAD. When you look to the RCA, you could appreciate tight narrowing in the proximal segment, as well as severe ISR that involve the distal RCA. So we went ahead trying to fix that. Initially, we start to pre-dilate the ISR lesion, as you can see here, with NC balloon. However, it didn't actually make any good expansion. Then basically we try to take the patient again and do IVUS. And as you can see, the IVUS showed in the proximal segment, like 360 circumferential calcium, as well as when you look to the mechanism of ISR in this patient, is a combined mechanism between underexpansion and new atherosclerosis. So again, we start to deal with the first lesion using initially 3O cutting balloon followed by shockwave. Both actually technology didn't work, so we went ahead with rotablation using 1.75 for the proximal lesion as well as the distal ISR lesion. After that, we managed basically to pre-dilate successfully this time with good expansion the proximal lesion with 3.5 NC. Then we went with the circumferential guide cataract extension to be able to deliver our basically gears distally. And that time we went with different actually devices using 3.5 by 15 cutting balloon followed by 4O NC. And still we didn't feel by IVUS that we achieved good expansion. So this time we went actually with a shockwave followed by 4O by 25 DCB Brevial from Medtronic. Then we basically stented the proximal lesion successfully with the 4O 22 millimeter drug-eluting stent. And this is excellent final results. So talking about the next indication or the ruling of DCP in ISR, we have tremendous evidence to support using of DCP in ISR and going with the recent European guidelines that drug-coated balloon is class 1 indication when we talk about ISR and PMS or DS. Now, important messages before when you deal with ISR, it's very common to have heavily calcified lesions. So your basically strategy to pre-dilate using balloon cutting, scoring balloon. If that was unsuccessful, you go to the next level using a very high pressure balloon, laser, lithotripsy, rotational atherectomy. And rarely nowadays we use vascular brachytherapy for these kinds of lesions. Now, a few things always to remember before ISR, don't rely on angiography, always use imaging. Do not assume there is only one mechanism because always there are multiple mechanisms for ISRs. Always modify the mechanical issues first, and then consider DCB always in preference to drug-eluting stent or basically permeable stent. Now, in the next case is 60-year-old male diabetic hypertensive smoker came with rhamnostenia and cardiogenic shock. ECG showed diffuse ST depression with very low ejection fraction around 20%. So we went ahead in this patient using Impella, and as you can appreciate, the LAD is subtotal occluded, as well as the severe narrowing involving the ongoing circ, as well as the OM branch. And at this stage, basically, we decided to do complete revascularization because the left system was non-dominant. So in this case, we pre-dilate the OM lesion, then we use 3O by 20 DCP Brevial from Medtronic. Then we went across the circ itself, and we put another DCP, another stent, one stent. So we ended up by having one stent in the circ, then DCP in that, basically I'm going to go in, avoiding having bifurcation stenting in this critical area, especially after we did open his LAD in the same session using another stent. So my conclusion, implant-free, leaving nothing behind strategies fulfilled by DCB use over a promising alternative to drug-eluting stent in the management of ACS. To date, clinical trials will talk about DCB in ACS and acute coronary syndrome are limited by relatively small sample sizes by the comparison of DCB against BMS and or all generations of drug-eluting stent and the short duration of follow-up. When you talk about what we need now, we need basically to confirm the role of DCB in ACS long-term by having a good RCT studies and characterizing the patients and lesions that would benefit from DCB use in those patients, as well as clarifying the choice of B2, Y12 inhibitors and or the need of the duration of that. Thank you for your attention.
Thank you, Abdullah. Dr. Raed?
Yes, please.
Go ahead, my friend.
Thank you very much for all the speakers. Actually, very interesting cases, and we have many questions actually from the participants here and the attendees. So the one question, I don't know to whom to direct this question, but Can we use more than one DCB of different drugs in the same lesion or the same vessel?
Well, of course, we can use it in the same vessel if you try to do and to treat complex lesions, including bifurcation. You have to use more than one. I showed a few cases where we use 3 DCBs. There are a few caveats that I would like to underline. There is no data to use 2 different DCBs in the same lesion. I would avoid using paclitaxel DCB, 2 of them, one after the other, in the same lesion, because paclitaxel has a narrow therapeutic window. So it has been studied for working at that level, at that dosage. If you add more, you can increase the risk of having also theoretically aneurysm, or you can increase the risk of distal embolization. In case of long lesions, I use more than 1 paclitaxel. I usually avoid using more than 3 for the same reason, because we don't want to, some of the paclitaxel and also some of the sirolimus, when you inflate the balloon, is lost during the inflation, is lost in the bed, in the vascular bed. The majority of paclitaxel balloons are crystalline, and so there has been shown in some animal data that there is an embolization of these crystals. So if you use more than 3 paclitaxel balloon, you can have an impairment in the distal flow. So that's my very not scientific limit of number of paclitaxel balloon that I'm using in the same patient, which is 3.
Excellent. Well, elaboration actually, and the worry about the no reflow after DCB in comparison to DES.
So I don't know if Don or Stefan has want to add something. We are running a study because, as I said, paclitaxel, 90% of paclitaxel balloon are with a crystalline formulation. So crystalline formulation in animal studies has shown to be associated with some loss of the crystals and cause potential necrosis in the distal vascular bed. But in human, there is no single data showing that paclitaxel is not a safe drug. So paclitaxel is completely 100% a safe drug if used with some of these caveats that I was saying earlier. We are running a study now comparing 1 sirolimus with 1 paclitaxel balloon in Italy, of course, because it's the de novo study, and we are doing a physiological assessment to see how is the microvasculature after DCB use. But so far, there is no data showing that one is better than the other.
Great. Another question about the acceptable dissection. I think you elaborate the physiological effect, but when do we accept the dissection and when we don't accept it?
I go ahead? Okay. So
seems everybody would like it.
Yeah, whatever, So what we usually say, and we write also, we wrote in the DCB arc, is that if you have a good TIMI flow, I was able to push the cutoff. There was a long discussion. We were at, I think, EuroPCR last year. There was a long discussion on which is the final acceptable person diameter stenosis after DCB. And some guys did say 30, because all of the consensus documents have always said 30. I was able to push it a little bit more to 40%. Why? Because if you treat a single 10 millimeter lesion, of course, you have to accept no more than 30%. But if you are dealing with such of the lesions that we have seen also in the cases today, long diffuse disease, you can also accept a little bit higher. I would say up to 50% focal stenosis after an 80 millimeter vessel that you have treated. That you can accept. So it depends. There is no strict number. It depends on the lesion.
And in terms of dissection, I mean, based on, in terms of dissection, for at least from my little experience, I accept type A, type B, maybe even type C, as long as no flow limiting to the distal vasculature. But to be honest, I think if you worry, just limit it to type B. That's the takeoff. And my first actually case, I left around 40% in the ostial, maybe a little bit of proximal diag. And then 2 years later, actually, it become even less on the follow-up angiography?
You can consider coming back to dissections. You can consider to work more on dissections with cutting balloon. You can do cuttering technique. Sometimes it's not effective. But if I hear 8 centimeter stent is the alternative, then you have to also keep in mind, is the stent indicated? Will the stent be detrimental? Will I have a good landing zone for my stent? All these factors make me spend some more time on the lesion and keep cutting and keep working on it.
So, Dr. Abbott, I have a question for you. So I was at the GEM meeting in Italy, and I was sitting near Antonio Colombo, and he said, if you want to do drug-coated balloon, don't do a lot of image, otherwise you will be scared. I'm sure he was joking, but he said, always it's gonna look ugly. And he said, I like to see dissection. This means the medication will go through this dissection to the intima and media and give more effect. And you know, and we observed also our colleague from Japan. Now they start to use systematically cutting balloon before putting a the drug-coated balloon, especially the Blaxetil. You know, they believe that it will go through this dissection for better medicamization of the fizzles. What do you think, guys?
Yeah, I think Bernardo showed some of the data on the dissections. I mean, you want to see some dissection for the efficacy of DCB. And so, yes, there are some randomized trials going on with vessel prep using either scoring balloons, cutting balloons. In the peripheral circulation, we certainly have data for that, also different vessel preparation. And again, I think you have to be leery about what you're looking for on the imaging. I think, you know, again, Bernardo brought this up again, because you don't want to overreact to finding small non-flow limiting dissections, non-significant dissections, you know, residual diameter stenosis. There's some debate of whether it should be less than 50% or whether it should be less than 30% by imaging to proceed or leave the drug-coated balloon results. So I think until we have further definitions, you can be a little bit liberal in using just angiography in your outcome, as opposed to, you know, drug-eluting stents, where we are more and more finding that the IVUS and physiology is really predictive. We just don't have that same data, although some early studies show if we use IVUS, you know, there's a potentially more improvement in positive remodeling, but we don't really have that full data.
Yeah, if I may add something, I agree with what Stefan was saying earlier and what Dawn is saying now. If I may add something, you should, you know, let's give a number. So which is a good and acceptable rate of bailout stenting after DCB? So we have data now. We have data that are showing that bailout stenting is associated with a little bit, a slightly impaired outcome as compared to solo DCB. Okay, unless, as Stefan was saying, you don't have to fear to put a short stent in a big vessel. It's not gonna get occluded. If you got rid of the lesion correctly, of the calcification, whatever, it's not gonna. A 3.5 by 12 or 15 stent is not gonna. Because don't fear to put it. But that said, if you have this bailout stenting above 10% of your casuistry, you should, I think, step back and work more on lesion preparation, or not use too much imaging after DCB to decide if to stent or not.
Great. We have a concern, actually, maybe in our region, about the cost. When you go for DCB, it will be more costly than DS, where you need more preparation for the lesion. You need cutting balloon, scoring balloon, and maybe imaging or hemodynamic study, or physiological study. So for one lesion to have this, the average cost, I think USA also they have very expensive DCBs there. So the average cost will be more costly now to do it. So can we make it more financially effective or more economic in a way or another? How can we skip, for example, doing the images, the hemodynamic study, when to do this or that?
Yeah, well, hopefully, like drug loading. Oh, go ahead.
No, sorry, no, please. I will follow
No,
you.
I was going to say, I mean, when the Cypher stents first came out, they were over $3,000, and now, you know, drug-loading stents are $300. So time will and competition will lower the cost. But I think for now, for the majority of lesions, you can do a one-to-one vessel prep with a balloon, and if you have a good angiographic result, apply the DCB. You don't have to make it too complicated. It's just the differential cost in the DCB versus the DES in your region. But again, the more complex the lesion type you're tackling, the more equipment you're going to need, and that may increase the cost, but that's inherent of the lesion complexity as well. So hopefully the difference is really just that final device, DES versus DCB. And if that cost differential is small, then it's probably worth it to the individual, maybe shortening DAPT, you know, having the potential to have the vessel re-intervened on with less difficulty in the future. I mean, especially for these young patients, you're presenting a lot of young patients in these cases where, you know, if I'm in my 50s, I would prefer not to have permanent scaffold in my artery. Like I would prefer to take slightly higher expense up front if it's, you know, reasonable for the health system. But I think the cost will come down.
Yeah, I think this is wise. We have to be patient. Competition will work. To make a story of it, in Italy now the stents are, you know, quite cheap. They are in some cases they are around 140, 140. In some other hospitals, because there is differences between public and private hospitals, they are around 300 euros. And DCB came down a lot. So DCB came out at 1,000. Now it's similar to DS, a little bit higher, but also if it's double the price of 150, which is 300, it's only 150 euro more with the same reimbursement, which is much, much larger. So that does not make the difference. The problems we have in the US, because in the US, we have reimbursement only if we use DCB for ISR, for outpatient, for Medicaid and Medicare, not for inpatients, for example. And I'm receiving a lot of patients with ISR from inpatient because they come very complex situation. And in these cases, I sometimes use DCB, of course, when I prefer not to use a stent, but it's not my first choice because of the cost. So now the costs are a big problem. As Don said, hopefully new DCBs are coming into the market. There will be new negotiation with the FDA and the cost will get down.
The cost comes mainly from IVAS and from FFR that you need more when you do DCB and cutting balloon. These are extra costs. Can you, Dr. Bernardo, tell us exactly or simply, when do you use IVAS, when do you use FFR in cases where you want to do DCB?
So after your answering, Dr. Bernardo, we're going to go back to there's tons of questions. We have to answer it, Dr. Raed.
Yeah.
Don't mind, please. Go ahead.
I will be very fast. So IFR, I am an imaging guy. I use physiology in 10% of the cases. For DCB, let's make 5%. So only if I don't want to put a stent because the patient is a high bleeding risk or it's a high, you know, ISR, I prefer to use a drug-coated balloon, of course, long stent. So in these cases, I prefer. So if I prepare the lesion, I still have the ducts on the data. I use physiology, but 5% of the cases. Imaging, I use it more. I would say I use imaging in my casuistry overall, which is a super biased casuistry of complex cases in 80%, 80 of my cases. And so it could be it could be DCB or DS. I use imaging, but as I said, for understanding the lesion mostly, or sometimes to understand if I have if I've done a good job in preparing the lesion, not for a final assessment.
Go Wail with the questions from the participants.
Yeah. So what is the role of drug-coated balloon in left main?
May I talk
Stefan,
about,
please.
May I talk about the future role? I don't know if you are aware of what's going on in Japan, that you have the DCA-DCB study from Nakamura, So I think it's going to be the future. Just considering the how the stenosis in the circumflex comes back, and it's so we are not successful. I mean, we know that we can, if we can do with the provisional, that it's rather good what we achieve. All the two stents techniques in bad vessels in the left main are not so great in the long run. So for the future, I expect a role there in the sense of ablation and you doing DCB afterwards. But right now, it's like provisional and do the circ, or do it the other way around actually, so that we can make sure that it's really saturated with the drug in the circ before I put the stent.
Interesting. So another question, doing kissing balloon in bifurcation using both balloon drug coated. Have you done it, Bernardo, before?
I've done it before, but I don't do it since 2014. I think
you don't do it anymore. So you do it before. Don't do it.
I've done it before. The early experiences. So my suggestion is not to use. I'm talking about de novo. I'm not talking about ISR or provisional. Okay, talking about de novo. So you want to treat a lesion, bifurcated lesion, with only DCB. So there is no reason for using a kissing for two reasons. One is because you don't have a stent. Kissing was invented just to respect the main vessel stent inflating the balloonary side branch. You don't have a scaffold, so you don't need. Second, you can increase the risk of dissection because you can imagine here. So this is the proximal vessel. Okay, the proximal vessel, you would inflate two balloons in this way. You risk a lot the risk of dissecting the proximal vessel, the main vessel. Third, there is a risk of losing drug. In a 6 French, which is the most commonly used access and guiding catheter for PCI, you can, especially with some paclitaxel-coated balloons, you can lose drug advancing to DCB. So I always do first the side branch with some protrusion in the main vessel, and then I use a second DCB alone in the main vessel for bifurcation.
So what about if there is ISR, both stent, bifurcating ISR and both of them, they show, like some narrowing. Repair the lesion with whatever, cutting balloon, NC balloon, then can you do kissing balloon here together?
You can, but you should not. So you prepare well the lesion, you decide not to put additional stents, so you use the side branch and then you use the main vessel. You shouldn't have that big carina shift. So the problem with kissing is that you have to avoid the carina shift and to distort, we don't want to distort the main vessel stent. So that's a stent implanted 1 or 2 or 3 or 10 years earlier. So you don't have carina shift. It shouldn't be an issue.
Drug-coated balloon and SVG in venous graft.
No, I've not. I've used it only for ISR in venous graft, not for veins itself. I have no experience.
Stefan,
it's a small registry showed it wasn't effective, but it is being used outside coronaries in fistulas, grafts, arteries, but vein grafts in particular, not so favorable data on registries, but we don't have any trials, as Bernardo was saying.
Okay.
We go for the native vessel whenever we can.
Anyone use compliant balloon after drug-eluting balloon where the medicine already delivered and you want to optimize the results? Small, like if there's small dissection or recoil or avoiding use drug-eluting stent at the end?
I do it sometimes. I try to avoid because of, as you said correctly, the fear of losing the drug. But sometimes if I'm not confident of the result, and again, if there is a good reason not for using a short stent, I do it.
What is, maybe, Stefan, what is the mechanism of positive remodeling after drug-coated balloon?
I don't have the data, but I think it's the flow. So if you do great lesion preparation and you open the way for good flow, this will probably be the reason for the vessel to remodel in the good way. But I don't know any data.
How about if you have aspirin allergy, an ACS, for example, like distal RCA with aspirin allergy, and it's true aspirin allergy, because I heard that the guideline is saying 4 weeks of dual antiplatelet.
Yeah, I would go just clopidogrel alone and do the measurements to make sure that it's in the long
So
run.
there are two studies that are retrospective, one from our group and the other from Thomas Rissanen, which are showing the safety of single antiplatelet after DCB alone angioplasty. And we are running a randomized clinical trial, which is Piccoletto 4, single antiplatelet versus dual antiplatelet. So we will have definite data, I think, in 18 months from now.
Okay. So with that, in the view of time, I would really, we're going to conclude this webinar. I would really would like to thank our attendee, a total of registered 272, the attendance per minute, 103 in and out, 17 country, 5 continent. What a great really number. And the reaction of the attendee was great. Thank you all our speakers. Thank you SCAI. Thank you AAPCI, and the Saudi Arabian Cardiac Intervention Society is always will continue to host such a beautiful webinars, and this is only the start this year. And we'll see you soon. Maybe the next webinar will be May 30 about renal denervation, and we will announce it soon. Thank you very much, everyone. Thanks a lot.
Thank you. Thank you, everyone.
Have a nice day.
Good time.
Bye-bye. Thank you, Raed. Munawwar.
Thank you. Thank you, Al Habibi.
Salim,
You did very
Abdullah,
well. Thank you.
Abdulaziz. Thank you, everyone. Thank you, Elizabeth. Where is Elizabeth?
She went. Everybody's
Right, she went. Okay, yeah. Thank you very much. Thanks a lot.
Thank you.